yeah, I'm slightly anxious now with all the experience in the room. So I'm Jill. I'm perinatal team manager, and I suppose my experience and history with EUPD is from mentalisation based stance. I was a MBT therapist with complex needs service for about 5 years before coming to perinatal. Some of what I offer will be based on sort of mentalising. And for those who haven't perhaps heard the term before, it's mentalising is basically thinking about your thoughts and how you're feeling and what other people might be feeling. It's kind of quite a complex term for something very simple that we do all the time, basically. So that's just the caveat to that. And I just wanted to. Sorry. Someone say something?
Sorry, that was me coughing. Hi.
No problem. I just wanted to start us off really with a quick reading from a paper to kind of set the scene. So you kind of have to perhaps close your eyes and put your creative mind into gear, because it's quite a poetic paper. Many of you have probably heard of it. It's called Ghosts in the Nursery. So I just really wanted to read the introduction to that paper to set the scene really for many people with EUPD come from a background of trauma in childhood, and it's just really to kind of start us off. So I'm just going to read the introduction. In every nursery there are ghosts. They are the visitors from the unremembered past of the parents, the uninvited guests at the christening. Under all favourable circumstances, the unfriendly and unbidden spirits are banished from the nursery and return to their subterranean dwelling place. The baby makes its own imperative claim upon parental love, and, in strict analogy with the fairy tales, the bonds of love protect the child and his parents against the intruders, the malevolent ghosts. This is not to say that the ghosts cannot invent mischief from their burial places. Even among families where the love bonds are stable and strong, the intruders from the parental past may break through the magic circle in an unguarded moment, and a parent and his child might find themselves reenacting a moment or a scene from another time with another set of characters. Such events are unremarkable in the family theatre, and neither the child nor his parents nor their bond is necessarily imperiled by a brief intrusion. It is not usually necessary for the parents to call upon us for clinical services. In still other families, there may be more troublesome events in the nursery caused by intruders from the past. There are, it appears, a number of transient ghosts who take up residence in the nursery on a selective basis. They appear to do their mischief according to a historical or topical agenda, specialising in areas such as feeding, sleep, toilet training or discipline, depending upon the vulnerabilities of the parental past. Under these circumstances, even when the bonds between parents and child are strong, the parents may feel helpless before the invasion and may seek professional guidance. In our own work, we have found that these parents will form a strong alliance with us to banish the intruders from the nursery. It is not difficult to find the educational or therapeutic means for dealing with the transient invaders. But how shall we explain another group of families who appear to be possessed by their ghosts? The intruders from the past have taken up residence in the nursery, claiming tradition and rights of ownership. They have been present at the christening for 2 or more generations. While no one has issued an invitation, the ghosts take up residence and conduct the rehearsal of the family tragedy from a tattered script. So I just wanted to share that with you. I find it very poetic and quite sad.
Very powerful.
Very powerful, yeah. Don't know if anyone wants to share any thoughts or feelings about that before we begin.
I found it quite interesting that I was able to really picture that in my head quite easily. I could go right there and think of everything you then said.
Hello, I've unmiked and unmuted myself. I'm not a particularly religious person, but it strikes me from from the Bible, I think, which can sometimes, and other religions, I'm sure, have real insights into sort of our psychologies. In that, there's I wouldn't use the actual. I think the actual quote is the sins of the fathers, and I don't think that's right. The sins of the fathers, though, are sort of passed on for up to 3 generations, and I think this is the same. This is the same thing. But I don't want to. I want to sort of de-religiousise that completely. But just the horrific things can sort of be passed on through our spiritualness or psyche, or I don't know what else. But I think it's happened from time immemorial, hasn't it?
Thank you,
Hand up.
Yeah, so I also found that incredibly sad. I suppose it reminded me of my own experience of being a new mother. I don't have EUPD, but I did find it so incredibly difficult. One of the most difficult parts of my life, actually. And, I'm someone I have quite a lot of privilege in different areas of my life. I have, other resources to draw on. So, I think it's really understandable that for people with EUPD who have often both the most distressingly intense, painful emotions and also very little support, may often be single parents or have abusive partners.
Yeah.
It's understandable that it can just actually be a time where it can feel overwhelmingly almost impossible to provide, reliable and responsive care to an infant or small child.
Yeah. Thank you. Okay, I'm going to share my screen. The initial part of the presentation is probably, very much something that most of us are all familiar with. Let me just go from here. Okay. So EUPD and the perinatal period. So just before we start, so EUPD, emotionally unstable personality disorder, still has the term personality disorder assigned to it. And there has been quite a lot of debate over quite a few recent years about the renaming of personality disorder across all personality disorders, but particularly with emotionally unstable, to make it associated with trauma, complex trauma, but that still hasn't happened. And so for the purpose of today, I will refer to it as EUPD, but I do recognise that it can be an upsetting label, contentious label. So I just wanted to mark that really. Here we go. So EUPD under the DSM, the diagnostic manual, is a pattern of inner experience that deviates markedly from individuals' culture. There are 9 personality disorders in 3 clusters, and EUPD, which is also known as BPD, borderline personality disorder, comes under cluster B. And the definition is somebody who has pervasive patterns of instability in interpersonal relationships, self-image, marked impulsivity that begins by early adulthood and is present in many contexts or various contexts. And individuals might make frantic efforts in avoiding abandonment, and will have unstable relationships, impulsiveness, maybe self-harming behaviours, unstable mood, and chronic feelings of emptiness. It affects up to 2% of the population, with 75 to 90% being women. And there are some various statistics there. 75%, probably greater, have a history of trauma involving childhood neglect, sexual abuse, psychological abuse, emotional abuse. It leads to interpersonal relationship problems, including issues of trust. And the people diagnosed with EUPD often come to us with help just to organise their internal chaos, their mental chaos, their kind of their mental and internal world. They may present to services as overly dependent or avoidant or chaotic or demanding, in the sense that they desperately need care, and they can be in desperate need. And the more severe the disorder, the less likely that significant changes can be made in recovery.
Jill, can I just interrupt? Are you moving your slides? They're not moving.
Oh, aren't they? Oh,
No.
okay.
You're still on the first one.
Oh, okay. I don't know what to do then.
I find in Teams on slideshow they don't move.
Okay. So what should I do?
Take it off slideshow. Let's move now.
Is it moved now?
That's better.
Okay.
Yes.
Yeah.
So symptoms fall broadly into 4 categories. So you have emotional instability, disturbed patterns of thinking, impulsive behaviour, and intense but unstable relationships with others. So when you receive a diagnosis, your personality features a number of traits and ways of thinking, regulating impulses, relating to other people. There are traits typically affect your self-image, how you see yourself or your body, or having problems with your identity. It will often cause problems in schooling and family life. And it generally is a result of genetic influences with your temperament and your personality that you're born with, and your vulnerabilities, and then the negative environmental influences, particularly during childhood. And being told you have a diagnosis of personality disorder can be like being told you're a bad person. Your personality is disordered, and that's what I think is very unhelpful, because we all have a personality. We've all got a disordered personality in some way, and it's just how much it affects your life on whether you get given this term or this diagnosis. And personality disorders aren't necessarily permanent. With therapy and time and age, you may not reach the criteria again if you were asked to be reassessed. So you're diagnosed usually by a SCID, which is a structured clinical interview, which is normally over quite a few sessions, dependent on the service. And that you would normally, within those interviews, sort of answer yes to these 5, yes to 5 of these questions. There's quite a few questions. There's about 8 questions, and you can see that they centralise on the fear of being left alone, unstable relationships, your sense of self, your engagement in impulsive activities, suicide threats and attempts, and self-harming history, mood swings, feelings of emptiness and loneliness, feelings of intense anger and aggression, and sometimes some sort of psychotic type feelings of paranoia or disconnection or dissociation from the world and your own body. So you can see it's very difficult. So attachment, so just briefly touching on attachment, because we often talk about attachment in psychodynamic work and perinatal work, and there are noticeable styles of attachment that a person will generally fall into. And you obviously have your secure attachment, and then you have the 3 insecure attachments. So insecure ambivalent, insecure avoidant, and disorganized. And those with EUPD would generally feel that they fell into one of the 3 insecure profiles. And if they were on an intensive program, there would be a sort of introductory program where they would learn about the different profiles and kind of get a sense and feeling about where they would feel that they fell into one of those. So it just brings about some self-awareness, which then helps to conquer some of the difficulties. So your secure profile is your attachment figure. Your parents normally have been consistent and predictable. Your mother or father or your carer was in tune with your demands. You learn to regulate your own emotions as a child, and you learn to sort of know yourself, who you are, that you're separate from your parents. And later in life, your attachments would follow this pattern. And as I said, just because you might be secure, doesn't mean your personality is perfect. You just wouldn't meet the criteria for dysfunction and into the EUPD profile. Then we have the first of our three, insecure. So insecure ambivalent is when an attachment figure has been inconsistent. So if we're bearing in mind the perinatal period, that this is us thinking about the mum who's come to our service, perhaps with a diagnosis of EUP, perhaps not, but with the traits that perhaps are considered indicative of EUPD. So that person has probably had a mother or father, attachment figure, has been inconsistent, unpredictable, and as a child she would have been perhaps excessively crying or clinging to her mum. She would have found it difficult to regulate her own feelings, and she would fear abandonment, and she would have stayed close to her parents or her caregiver, but it would have taken her quite a while to be comforted by her. Insecure avoidant. So this might have been someone with a parent who ignored her or overlooked her distress, or sometimes even teased distress. So the distress is not soothed. She wouldn't have been soothed by her parents. She would have learned to not expect any comfort, and would then go internal and would express herself internally and perhaps wouldn't show any response. And this would possibly come across in adulthood as detached or very cut off, and experiences physical distress as well. So that sense of these psychosomatic issues that we see a lot of, that it comes out in the body, the stress. Then we have disorganized. So the attachment figure would have been violent, abusive, neglectful. It could have been any which way on any given day, unpredictable. So the child would have been very tense, anxious, fearful, cut off, and they would have found ways to cope, maladaptive ways to cope, that then follows them into their adulthood. Not maladaptive as a child, but as an adult. They might dissociate, and they would be overwhelmed by threat of fear, which wouldn't easily be expressed. So if we are secure, or if we find therapy helpful and we use therapy, we can learn to be more secure in ourselves, and that can help us to be more aware of our own feelings, develop better relationships, start describing how we feel, deal with attachment conflicts. So knowing why we feel conflicted in relationships can help us kind of deal with that and improve our ability to sort of mentalize how we're feeling and how other people might be feeling, and understanding relationships between others. So the struggles, so there's interpersonal difficulties that people with EUPD will struggle with. Sorry, my phone keeps going weird. So if you have trouble being able to understand another person, it's likely you won't be able to take into account their feelings or needs, and you might misunderstand what they're saying or doing or why, and this can lead to conflict. Emotional difficulties. If we have trouble mentalizing ourselves, we'll lose the ability to move beyond moments, and we start catastrophizing. We might use harmful acts to deal with our emotional pain, and this is then often followed by shame for what we might have done or said, and also sort of the harmful acts, that the self-harm or the suicidal behaviours, which obviously in perinatal care we do have to report, stir up feelings of shame of social services when we have to sort of have that conversation and getting them involved, and that can bring up old memories of social care, being involved in their own childhoods perhaps, or the shame of that, and or the fear of that, and the traumatic experiences, coping with a new pregnancy as well, with all the traumatic experiences that are brought up perhaps during a woman's life when she's pregnant and she's having a baby, which we'll look at shortly, which is also going to be difficult. So you're pregnant, perhaps perhaps it's your first baby, perhaps you've got other children. There's the unknown, and the unknown can be quite difficult to tolerate for anybody. But when you have a diagnosis of EUPD, it can be even more difficult, because the stability that you've perhaps learnt to use in your life is going to be wobbled. So there's changes in your role, your body's changing, your role's changing, the future's uncertain. There might be losses of some kind, relationship losses, job losses. You might lose friends, for example, if your friends don't have children. Your work life might change. Your job might be keeping you stable, and actually you might lose your job, or you know you have to leave for a little while. The relationship with a partner might change. Often women are really concerned about the relationship with their first child if they're pregnant again. They're perhaps very close to their first child, and they really can't quite grasp how that child's going to cope, if it's going to change their relationship with that child, and that can feel very anxiety provoking. And obviously body image with the body changing. I can't see if there's any questions because I can only see my PowerPoint, so do let me know or interrupt if I'm bombarding you too much.
You're okay for the chat for now.
Okay. So the maternal concerns that we see are mum being very worried about baby inheriting mental disorders or difficulties, not being a good mother, thinking that they're not going to be able to be a good mother, or that they're going to be judged a bad mother. And if there's a history of self-harming or suicide, there's the anxiety and the worry that their baby will be taken away, relapse and difficulties, pregnancy triggering old traumas, for example, sexual assault. We have lots of ladies who have got sexual assault trauma in their past, sexual abuse in their past, and the thought of having the sort of internal examinations, having perhaps a male doctor in the room, having people touching them, it can really stir up lots of old trauma. They're worried about alcohol or drugs that they've perhaps consumed before pregnancy, or perhaps they've got a dependency on something, and how they're going to manage that. And we had a great talk on domestic violence earlier in the week about how it can really escalate during a time when someone becomes pregnant. And there are often relationship histories of domestic violence, and how even how a partner might react about the pregnancy if it's unplanned. So there's all these concerns that come with perhaps the excitement. So the unique position of the perinatal clinician. So we keep not just one person in mind. Obviously, we've got an unborn in mind, or a baby in mind, and we have other children in the household, and dad or partner. And so we really do try and keep the whole family in mind. We are hoping to move towards looking after families rather than mums. So we really have to kind of bear in mind that there are other people in this family, and we try and include them. We try and include dads. We do often try to see mum on her own, perhaps for the assessment or at a different point, to just make sure she's got some space to talk about any issues she might be having with partner in regards to domestic violence and things like that. But yeah, we do try and look after everybody. We also have to obviously work with all the different services, the midwives, the health visitors, the social workers, and we try and really kind of team up and provide really good care. And if someone's got social services involved and mental health midwives involved and health visitors involved, often it's too much. to have all these people wanting to have appointments with you. So we have to be really mindful of that and give people space, but also be there for people as well. So trying to really be mindful of that. And the safeguarding issues is always an issue. So it's really, from the very beginning, we try and be very transparent about safeguarding, particularly if there's a history of self-harm. Any self-harm we do have to report under the London Child Protection. So having that conversation, particularly when you're building or you've just built a therapeutic relationship, can be really quite tricky. But it often works out okay. But it's unfortunately something that we do have to do. But it is hard. There's an opportunity for prevention to break that sort of intergenerational trauma. And a lot of women who come to us say they want to stop the cycle. They don't want their child to have the same childhood that they did. And so there's that sense of new beginnings and wanting to work with that. And we know that the reason why the perinatal service is growing so much is because we understand that coming in at this time is really beneficial for the child, for the future. And I think particularly with women with EUPD, I think they really, really need our service. And I think it's really important that they are up there with in the criteria of who we treat. So I'm quite passionate about that. And I think providing a foundation of care to keep the waters calm in a stormy time. Often we can only be the container because there's so much happening when you're pregnant and you have a baby. You can't really do a lot of intensive work with somebody, but you can contain that until and keep them going until they've got a bit more space in their life to enable them and equip them a little bit more to then go on and do therapeutic work. So I missed a few things out on this slide actually, and I couldn't work out how to then add it when it had been all poshed up like this. So apologies if I've missed people. So interventions within the team, we do offer a huge amount of interventions. Our perinatal team has been given a huge amount of training, and we're just kind of really trying to unpick all the training and work out how we can best use it. So we obviously have our nursing care for home visits, and we have our psychiatric care and our psychological care. But we've also been trained in various different things. We have our VIG therapy, which is our video interactive guidance, which we do in homes. And there's quite a few of us trained up for that. I think 3 of us are currently doing our accreditation and being supervised. Our VIP interventions, video feedback interventions, one of our psychologists does that. We've all had our DBT training, and we have recently set up a sort of DBT supervision group where we're going to try and work out, maybe our Sutton and Merton colleagues can be a part of that and helping us, but we'd like to run a DBT group. It's quite difficult to do the sort of very intensive program that often DBT is made for, but we'd like to run a DBT skills group, and that's particularly good for those with self-harming. MBT, we are all trained in MBT's reflective parenting as a cohort of perinatal team. And we're trying to kind of figure out a way where we could perhaps do groups for that. It's just COVID's really kind of got in the way of our agenda really, but perhaps the online working might actually facilitate that better. Our Circle of Security parenting course is running regularly online. That's well attended and really well thought of. And we have our PIP team, our parent infant psychotherapy team, who've literally just joined us within South West London St George's. They have been working alongside the Wandsworth team in Chelsea and Westminster, but they've actually just come to join this trust, so that's quite exciting. Unfortunately, that's only offered at the moment to Wandsworth mums. So we do aim to offer as much as we can the right treatment for the right person, and the family and couples therapy, I think, is huge waiting lists. So it's often something that we can only refer on to and not see within the span of our care, really. I don't know if anyone's got any questions about that. I think this is the last slide. So I was just thinking about pregnancy and childbirth triggers. So what?
So I just have a question. I don't know how you want to do it, Jan, or.
Yeah, this is the last slide. So I'll do the last slide, then we'll have some questions and discussion. Brilliant, thank you. So pregnancy and childbirth triggers. So what I think we often see, I'm sure there are more than this, and perhaps we can think through some more, but the old wounds of being parented are at risk of being exposed, and often being pregnant, particularly for the first time, it really kind of stirs up in our new mums about what it was like for their own mother. And if that relationship was very difficult, it can be a real trigger to perhaps old behaviours that maybe that mum's not used for a long time, such as self-harm, going back to sort of old habits, eating disorder habits, can be quite a trigger. And we see a lot of re-emerging eating disorders and body image issues. And then you often have mums who feel really important and loved when they're pregnant. They're very important. They go to, they're seen by lots of different people, and that can be really nice for mums. And actually, it can be a bit unsettling, I think, because there's a real need in a subconscious way that isn't being met, and feeling wanted and important can stir that up. Trauma of sexual assault, I've mentioned that, and the processes of pregnancy and birth, being touched all the time, having to do lots of physical examinations. We have many instances where we have to do a really kind of tight plan for looking after that mum during that process. When baby's born, breastfeeding, how difficult that can be sometimes for women with intimacy difficulties. That can feel quite hard. And then the sort of last two are really on a kind of seesaw of the extreme ends of sometimes what can happen. So envy of the baby. So baby comes along and mum feels really unimportant and envies the baby's attention that everyone's giving to the baby. And that can be quite difficult, because then she can feel an enormous amount of shame that she perhaps feels like that. And then you get the opposite side, where we'll have mums who want to have more babies. They love being needed by the newborn. They love being important and loved. And that newborn being so dependent on them. And they had a lady recently, and she just said, I just feel so important. I just want to have another baby. And I think that those sort of opposite ends are often a spectrum that we see. And that's it. So I'm just going to stop sharing my screen.
Great, thank you, Jill. That was really good.
Thank you.
I'm echoing a little bit. We've got a hand up from Marina.
Just
Can I ask?
So yeah, just to say
can I ask
that,
a question? Oh, yeah, questions.
Yes, just Rowena's had a hand up, so I'm just going to ask Rowena to do her question. I'll come to you in a minute, Nina.
Okay.
Thank you.
sorry, that's the time delay on the internet, isn't it, sometimes? I just want to say thank you very much. That was really helpful to go through that and to understand a bit more about what the service offers. I suppose I was just thinking about how the services work, because obviously we provide in Sutton and Merton complex needs therapy for women with a diagnosis of EUPD, and we quite often have new mums, and we work with them. So I suppose I'm just thinking that sometimes when we've referred through the referrals being rejected because they're already under us, and other times mental health midwives are referred, and even if the patient didn't want it, the referral's gone through. So I'm a bit confused about what the kind of referral criteria and it isn't with EUPD, and when you might accept someone with that diagnosis and when you might not.
Well, I think often when we have a client who's well established under another team, under CPA, for example, and undergoing a treatment, we will just kind of be an add-on to that, and more of an advice, and if there was a particular perinatal intervention that we could provide, we would provide that. But I think we don't want to kind of swap and change, because we're only with people for a year, and I suppose we would want to provide an add-on. I mean, I think ideally we'd always want to work in partnership with anyone that you would want to refer.
So what would the add-on be? Because I suppose that's the question. If somebody's in a full, say somebody's in therapy with us, which happens, and they then during that time have a baby, what could you offer as an add-on?
I suppose it would be, I mean, it would be obviously on a basis of seeing what that person would need at that time. But I suppose there's nursing care if that person needed home visits when the baby was born, for example, or medication reviews from a perinatal perspective. And there's obviously perinatal psychology if there was an issue that actually was a sort of a perinatal issue that came up during pregnancy and birth, rather than something more long-standing. But I mean, I was always under the impression that it was quite difficult to do quite intensive therapy when you were pregnant or had a baby. I was under the impression that perhaps that wouldn't happen, or it'd be postponed, or
we're mother-led by that.
Okay.
Yeah, so I'm working with someone who's pregnant at the moment, and we're just mother-led. Some women don't want any maternity leave from therapy at all.
Okay.
Continue on, and other women do want to break. So I think we look to be mother focused about that. I suppose the thing that I'd be quite interested in as an add-on, something we can't provide, is potentially the circle of security group, something like that is more about mum and baby. That obviously we don't provide that, so that's something I think could be quite a useful add-on.
Yeah.
So what would be the process of referring someone to that? Would that be something that's possible, or is it kind of?
I think so. Yeah.
Okay, thank you.
I think one of the things to remember is that we're always going to have the baby in mind when we're working with our families, and we're thinking of the wider picture and the impact of having a baby. And the postnatal. So because we have lots of training in various aspects, such as the attachment focus, the reflective parenting, I think it just makes we see things slightly different, and we'll have another spin on things, or a different angle of what's going on here. So it's an additional, it's a whole package really for somebody as well, if they're already open to another team. It's just making it a bit more robust, because we know those early years are so important for what happens longer term, and the impact on that child and that relationship. So I think that's why we pour a lot of kind of work into that first year, and hopefully we'll be extending to the 2 years as well. So we're not unique in its way, but because we need all the other services to be able to still offer what they do as well, and we try and tailor it a bit more.
Yeah, I mean, I've got to drop off the call now, but I'm very willing to talk about the standalone DBT group, or things about how we can sort of, dovetail some things. Then, perhaps that might be a good next step.
Yeah, brilliant.
Thanks very much, though. It's really, really useful. Thank you.
Thank you, Irina. Nina, we'll go over to you next. Oh, you're on mute.
Okay.
Yeah.
All right. I'm coming to this obviously very much in lay terms, I am fascinated. I'm very fascinated by what you said, Jill. And having worked with lots and lots of parents over the years, it certainly makes me think about some of the people I've come across and what really was going on for them, completely undiagnosed, of course. But I'm just wondering about referral. And obviously, if you've already been working with a woman and she then becomes pregnant and you perceive there's a problem and likely you carry on, how does it work for women where this has never been particularly picked up before? They have their baby and then they start showing behaviours that fit into this pattern, but who is responsible for picking up on that? Because I don't know whether does this show up very, very quickly, or is it something that would be worked into? I mean, obviously postnatal depression would often be diagnosed, but how do people know that it's got a little bit beyond that?
Well, I think it would follow a referral pathway, really. Someone would go to their GP and perhaps have some sort of diagnostic tool where the GP would pick up that the person's struggling, and then we generally assess all our referrals. So there would be quite sort of in-depth assessment at that point, where we would sort of go into the family history and her personal life and things like that. And that might be the first time that person's had an assessment like that, or spoke to someone about their life and their difficulties, and it would probably go from there. And a package of care or some psychological work where perhaps that would come out, and that person might then move on to have more sort of a deeper assessment, further assessment, or just have a period of time with us in our team while she's having her baby, and learn some skills to manage things that are happening. But I don't think there's any particular point where it will just sort of it's very unique to the person, their journey, where it would come out. But often pregnancy can be a trigger. Pregnancy and childbirth can be a trigger to old trauma that perhaps hasn't ever been processed or thought through, or perhaps the woman's just been managing it all of her life.
Yes. And so when the sort of checks that health visitors make, for example, where they do have certain questions, don't they, that they ask? I know a lot of women are driven absolutely crazy by that and feel that they're a bit pointless. But is it this sort of thing that would be underlying those questions? Because they always seem a little bit of a blunt instrument, but are health visitors trained up so they could perceive if it was something as deep as the issues you're talking about?
With the tool that you use, you mean, or?
Well, yes. I mean, well, I suppose a mixture of the questions, whether the questions are suitably adapted to get to the bottom of some people's states of mind and feeling, or whether health visitors get any sort of specific training in looking for EUPD.
I don't think they do. I think Jill's probably a good person to answer that question. I don't know if she's still here.
I don't think, I mean, I can speak from when I was a health visitor, we didn't have any training. It's very much, we refer on to mental health, but I think they definitely have been asking for more training and understanding. And I think they want to be able to help the women that they see, but they don't always know what to do. So that is something we have a plan to offer training to our health visitors and midwives, and that will certainly be one of the topics that we will be looking at, because we recognise it's a gap in training across the board, really, as well. It's been raised in perinatal teams across the country as that we need more work and more interventions available and understanding about this particular client group when they become pregnant or have a baby. Yeah.
Okay, thank you. Rosalie, you've got your hands up.
Thanks. I suppose just in response to your previous question, Nina, I think it's very difficult. It does require a specialist mental health assessment to make sure you reach an accurate diagnosis for someone with these difficulties, because not everyone who self-harms has this diagnosis. So I think what's helpful perhaps for you know, perinatal visitors to do is to be able to flag up when there's a problem and then help the, you know, signpost and refer to mental health services. Because I think they can't be expected to do the diagnosis themselves. That would be a kind of specialist job. But I guess I'm just wanted to check if I'd heard correctly. So apologies if you've already explained this, but so is it correct that a woman would be able, or a mother would be able to access mental health services and also your service because we've previously had that declined, particularly where the diagnosis was EUPD, so there was no role for medication. So it sounds like you're saying that's changed and now that is an option.
Well, yeah. I mean, I would hope that we wouldn't decline someone just because of an EUP diagnosis. No, it's not what our team is meant to be doing.
Right.
We want to advocate for women with EUPD as much as we do with anybody else with a mental illness.
Yeah.
Having that diagnosis is definitely not a barrier to getting access to perinatal care. And I think because we cover 5 boroughs, we do find every borough service is different and has their own kind of criteria, and it's all slightly different, and it does cause confusion because in one borough we could work jointly and have a really great relationship, and on another borough we could be battling as to who does what and actually get nowhere, and in the middle of this is a woman who really needs some support. So I'm definitely putting it out there. It's not a barrier for accessing our help. We will see everybody and anyone who needs us.
Thank you so much. I have to leave, but thank you very much. It was really helpful.
Thank you. Thanks.
Thank you.
Got a question from Keith. He's going to tell us what he was eating earlier. Sorry.
Oh, well, if I must, yeah. It's not a question, it's really just a statement. I've just been really encouraged by what I've heard today. It's been so reassuring. I think for those people that maybe don't know this client group as well as maybe I do in terms of working in the complex needs service, or other people who are working with this client group. This client group is often very stigmatized, often very excluded, because often repeatedly rejected by services because of their behaviours, which can be very misunderstood. I am just so pleased and so encouraged to hear what's been discussed today, and you know, I hope that Sutton and Merton Complex Needs Service is a service that we can have a great working relationship together with you, you know, because I think absolutely we're sort of singing off the same hymn sheet. Having real sort of feminological empathy for this client group and a real understanding of the difficulties and you know, even though the behaviour or what is presented is very challenging, not just accepting that, not just validating that behaviour, but validating the reasons and causes and having a real understanding, I think is so important. So yeah, I'd just like to mark that as my take on what's been presented today, and thank you. It's just been really sort of it's been music to my ears to hear what's been discussed and said. Thank you.
Thank you, Keith.
Thanks, Keith.
I think it's also to say, actually, we've got a lot to learn from people who are already working in those teams. And so if we can get this conversation going and look at, you know, tailoring whatever intervention we need to make that journey a good experience for that woman, it would be really, really helpful. Are there any other questions? We're coming up to ending. No? Right. Well, we've got another session straight after this at 3 o'clock. Kelly, you've got 6 minutes to get ready because you're in this group.
Yeah, thank you.
Thanks. And it's on infant brain development, and hopefully the links have been put in before I think Emma left as well. So And then we've got some more sessions tomorrow. We've got father's session. We've got one of our project, Mind the Dad, Alex, coming to do a talk, as well as another infant brain development from a psychotherapist. And then later on in the afternoon, you can come and meet the team. We just have a check-in on a Friday afternoon if you want to see some more faces and have a, we might even throw a quiz in at some point if we can get organised enough. But thank you very much, everybody.
Okay.
Thank you, everyone.
Thank you.